We'll start with the first rib. Now, finding the first rib is a little bit of a task, but you've got to do it, because just to assess the first rib, you need to be able to find it, obviously. If you come down the side of the neck, you'll hit this big lump of bone. Don't press too hard, it's quite tender. That is the transverse process of C7, the largest transverse process in the cervical spine. And very easily notable. If you look at the skeleton, you can see what a big lump it is. Now, that's an easily identifiable point. What you need to do is come down and out just about ½ an inch. You'll be over the tubercle of the first rib. Very hard to feel it, because it's covered with so much muscle. And many times when we're doing surface anatomy, it's the assumption with your knowledge of anatomy as to where that structure is. Find C7, and then the tubercle of the first rib is not that difficult. Take a breath in. And what you're going to feel is, as she breathes in, it rolls like this. It rolls downwards. With my finger on the body of the rib, it comes upwards. So I look at that movement and I realize, okay, there's the classic pump handle motion. Rib coming up at the front, the tubercle going down. There's no other motion available at that joint. And that's because the transverse processes are basically like this. So the rib cannot move posteriorly, cannot move laterally, because it's stuck to the body of the rib. So all we see is this very classic pump handle. But then what we're going to notice from here, there's a very definite change. Even the second rib, we look at the transverse processes, and they are starting to become less coronal, and eventually down in the 10th, almost sagittal. So that is definitely going to change what we are palpating as we're looking at the ribs. So I'll just go to the second. Take a breath in. And immediately you see, okay, yeah, I can see a lateral movement coming in. It's still a kind of a pump handle movement, but it's gliding laterally. Take a breath in. You see that? That lateral glide. Breathe in. All part of the expansion mechanism. But now I'm going to take a quick trip So now I'm over probably the 9th rib. Take a breath in. What do you see now? And let go. Breathe in.
Posterior, yeah.
It's posterior. Where do you think the driving force is for that posterior glide?
A diaphragm.
There. This vector. Just swing around a little. Actually sit on the end. If I look at Haley's sternum and I put one thumb just below the sternomanubrial notch, one above the xiphoid, I look at the angle and it's like this. This is the angle of her sternum. Take a breath in. But when she's breathed in, she goes from here to here. Because the diaphragm, as much as it's lifting the xiphoid sternum up, it's pulling it backwards. It's doing this motion. And that in itself explains the existence of one particular structure. Doesn't it? Oh, look at the manubrium. One on the top, one on the bottom. Breathing. And this is different because she starts like this and she ends up here. So the manubrium is doing this, the sternum is doing this as we raise up. What do we need to accommodate that? The sternocleidomanubrial joint. That's why it's there. Because of this action that's created by the diaphragm.
That's not fused. I thought it said.
Even if it's fused, it's rarely fused.
Oh.
Sometimes it's a fibrous joint. Most times it's synovial. It fuses, or it tends to fuse as we get older. That's where that comes from, is because most of your cadavers that are studied are 70 plus years old. But in an average young adult, it's invariably a synovial joint. Can be fibrous, can be cartilaginous, but it always moves. Not like these. That's where that problem comes from. And, some of this skeleton is awful. This is the worst skeleton I've ever seen. This person has Paget's disease. Mainly the skeletons I used to work with were real, and we used to have this what's called a manual therapy kit. So the company used to send people boxes with specific bones. They'd always include a manubrium and sternum, and they'd always be separate. So not fused. And if it is, many times that is abnormal. And in fact, in many of your patients that have central pain, it's because of their mouth breathing habit. What it does is, you know, talking about mouth breathing, they say, oh, you're an apical breather. It's like, okay, so who isn't an apical breather? You don't want to fill the top of your lung? What happens is, with the forward head posture, which goes with mouth breathing, the diaphragmatic tone increases. So slowly, the lateral costal margins are going to increase. Until in the end, you've pretty much exhausted the motion in your lower ribs. But what's happening here? They're down. In expiration. The only place you have left to breathe is the top two ribs. So that's where you go.
Why does that happen again? Can you explain that?
With the forward head posture, remember, it adds weight to the front of the chest, so your diaphragm increases its recruitment. And as this condition worsens, the recruitment of the diaphragm means it won't relax. It just keeps inflating the lower costal margins more and more and more. Till in the end, there's very little left. It's not a problem you can't breathe in from there, you can't breathe out. But up here, we've got the opposite, because these guys are dropping into expiration. So the only motion left is here, apical. So we see people apically breathing. Typically it's a mouth breather with a forward head posture. The trouble is, they go to therapy and the therapist goes, apical breather. No, I'm going to teach you how to breathe with your diaphragm. See where that's going? I want you to think of breathing and filling the lower part. Breathe in and out. And your chest is going, what the hell? I'm already about to explode. You want me to increase the activity? what we should be doing is saying, take a breath in and sigh.
So you should be working more on the expiration.
Expiration, relaxation. And as I said, in Britain, respiratory therapy is huge, and we would be dealing with hundreds, literally, of asthmatic kids. And these children die when they reach what's called status asthmaticus, where they suffocate because they can't breathe out. And if you can't breathe out, you can't bring any more air in. It's a terrible problem, especially when you're looking at the age that this attacks. So this was a big deal for us. And first of all, we'd have to teach them, because they'd be like this, right? So we teach them to open their chest up mechanically. But then one of the classic exercises, and I loved it, because you've got feather pillows, pull out a little feather, and you lie them on their back with their knees bent. You say, okay, see this feather? I'm going to let it drop. I do not want it to hit your face. Keep it up. So of course, first of all, they go, because their forced expiratory volume is still limited, but that's all they can do. And eventually, they play. It's a game. You've got to learn to play games with kids in physiotherapy. And so in the end, they're going, and you can see this feather just hovering. And you think, gotcha. That's diaphragmatic expiration. That's our emphasis too, which we're going to see when we change somebody's posture. Can you teach them to breathe out slowly, relaxed? You can't force it. Teach them a slow, relaxed expiration. Start to regain the control of the diaphragm. You've got to think, how many forward head postures do you see? So here's another fact, right? They're probably breathing at 50% of their optimum efficiency. 50%. And of that 50%, because they're breathing through their mouth, they've cut their blood supply down to their brain by 50%. It's like, oh, this is not a good situation. No, it isn't a good situation. Because you have no idea usually how that's affecting their life, their personal life, because they're not going to come out with that. But you can pretty much guarantee it is. Okay, so that's why, cut the story short, why we have sternomanubrial junction. Sometimes, because we're breathing with this so much, it can become hypermobile, sometimes even subluxed. And when the patients point to this very simple technique, you can just take the sternum and pull it down, literally distract it, and it goes boom. And you can teach the patient to do that themselves. Because obviously we don't want to go anywhere close to surgery. Prolotherapy has limited value, and if they learn that that's what they have to do, it's not dangerous, that keeps them functioning. Okay, so that's what we're seeing at the back, that movement. So we start with a simple pump handle. Second rib, lateral. Gradually, if we go to the bottom, it's more posterior. So most of them in the middle have a posterolateral glide on inspiration. Anteromedial on expiration. Swing your legs down. But here is the most interesting part of rib mechanics. I'm just inside the angle of a rib to palpate, and what I'm going to do, Haley, turn your head to the right and left. Can you see what's happening? And face forwards. To the right. Watch my right thumb and forwards. to the right and to the left. Notice when she's turning, her chest isn't moving, but her spine is. Remember, to counter that, to stop this having to move, this rib, when she rotates right and the transverse process is trying to come backwards, the rib cancels that out by moving anteromedially. And then, when she breathes in, posterolaterally. So we've got anteromedial, posterolateral. The same movement is utilized in right rotation, anteromedial, left rotation, posterolateral on this side. So, can you guess where the biggest source of rib subluxations is coming from? Imagine an event where we fixed the chest, but we forced the head to move. What would that be?
MVA.
MVA. Rear end collision. Most people are looking in the mirror, they're talking to their passenger, they will rotate. So the question is, what precipitates that rib subluxation? Why does it happen at this particular joint and not others? From a therapeutic perspective, you've already stated to me that, yeah, a lot of your patients have forward head postures. Too many. And a forward head posture produces what lesion predominantly in the thorax? See if you were listening to me yesterday.
Anterior subluxation.
An anterior subluxation. What does that do to the rib joints, or more specifically, the costotransverse ligaments? What does that mean? Yeah, it stretches them. It stretches them. It weakens them. We now got a less than stable segment. There's your victim. It's almost always related to the segment that is stuck forwards. Which way it goes is dependent upon which way the head is turned. So quite often you manipulate a joint, you still have residual pain, you go in and check it, the rib, boom, there it is. Subluxation. You fix the rib, you stress test it, and you think, uh-oh, it is very loose. And you know that if that rib is not stable, the segment cannot be stable. There's your classic candidate for prolotherapy. In Kalamazoo, is there a surgeon that does prolo? A tall, lanky guy? Who, and his sister's also a physician? No?
I think everybody's referred to either Chicago or something.
Okay.
Sometimes when we use them. It's in St. Joe.
Right. He moved. He was going to move to Boise. When he shook my head when he said that, I went, Boise? I teach in Boise. It's like, but that's enough for me, 3 days at a time. No, it was because when I lectured on prolotherapy, he and his sister were really interested in taking it on. So hopefully they did. But that's the... Because with prolotherapists, you've got to remember they're physicians. Not to denigrate them, but they don't know very much, if anything, of surface anatomy. So you have to take them and say, that's how you have to go in. There's the needle going in like this. Into the costotransverse space. That's how we stabilize the segment. And you are the only person that will know when to stop it, because they won't be able to feel the infeel of an unstable rib. Understanding this means this is great because we can use 2 comparative tests. We're not going to assess every rib joint, are we? Why not?
Time.
Time's a factor. Especially if you're seeing 70 people a day. But,
Yeah.
Pass out. They would pass out.
yeah, right. They're going to faint. We don't need to because of this lovely thing. Remember? Hypertonus of rotatorius. That line is everything. If you can't get to find that hypertonus, then you might as well give up, because you're never going to find the lesion in the thorax because it is so dependent on hypertonus. The rib, if you've got a rib dysfunction, it will cause the hypertonus. So we really only need to go the one above, suspect joint, the one below. But we don't even need to use breathing, because we can use head movements. They're not going to pass out with head movements. Unfortunately, of course, because of the prevalence of MVA being responsible, they might not have the movement in their neck to produce this movement in the rib. Okay, so this is the assessment, not up and down. That's for the first rib only. From the 2nd to the 10th rib, it's going to be looking for the posterolateral glide that's occurring, both with respiration and head movements. Supposing you had a difference, you find it in respiration, right? Breathing in, breathing out, moves normally. When you move the head, it doesn't seem to move. What do you think's wrong?
Turn those processes stuff.
No.
I say muscle related then, because if the joint can move in one direction using respiration, but then can't do it with activity, then it has to be muscle because of a motor control.
It does. So why is the muscle reacting aberrantly like that?
Insert you.
Because it's unstable. Remember, in the lumbar spine, side bend right, side bend left, everything's looking hunky-dory, but they can't extend. Why? Muscle intervenes. They go into muscle spasm because the muscles are protecting the instability. So you get the same problem here, the inconsistency. Whenever you have 2 tests that utilize the same motion, but they're not consistent, instability is going to be at the bottom of it. Doesn't matter whether it's in the neck, lumbosacral junction, SI joint, or rib. Okay, let's practice.